Welcome back to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, here with our guest, Jessica Glennie, and this is part 3 of our EULAR ILD wrap-up. We are covered some interesting information thus far, and in this final episode, we will wrap things up. So let's go ahead and dive right in. I will start us out with talking about abstract POS 1270. Prevalence and risk factors for interstitial lung disease in patients with rheumatoid arthritis receiving treat-to-target therapy from disease onset. 10-year follow-up of the ARCTIC trial. An overview of this study, this 10-year follow-up study from the ARCTIC trial, evaluated the prevalence and characteristics of rheumatoid arthritis-associated interstitial lung disease in patients treated with modern treat-to-target strategies from time of RA diagnosis. Investigators also examined clinical and demographic risk factors associated with ILD development. The background: RA-ILD is a serious extra-articular manifestation that contributes significantly to morbidity and mortality. Although treat-to-target approaches have improved joint outcomes in RA, less is known about the long-term impact of modern management strategies on ILD risk. Current guidelines recommend proactive ILD screening in high-risk patients, but optimal monitoring approaches remain uncertain. This study aimed to better define the long-term prevalence of RA-ILD and identify associated risk factors in a contemporary RA cohort. The methods: patients originally enrolled in the ARCTIC trial across 11 Norwegian centers underwent high-resolution CT imaging 10 years after initial RA diagnosis and treatment initiation. All participants had received structured, tight control, treat-to-target therapy early in their disease course. High-res CT scans were centrally reviewed by thoracic radiologists and multidisciplinary teams, including pulmonologists and rheumatologists. Additional assessments included pulmonary function testing, dyspnea and cough scores, and evaluation of demographic and disease-related ILD risk factors. The results: RA-ILD was identified in approximately 9% of patients at 10-year follow-up, despite early aggressive RA treatment and high rates of disease remission. Most ILD cases demonstrated indeterminate fibrotic patterns rather than classic UIP or NSIP presentations. Patients with RA-ILD had significantly lower DLCO values and higher respiratory symptom burden, including dyspnea and cough, compared with patients without ILD. An additional 19% of patients demonstrated other nonspecific interstitial lung abnormalities on high-res CT. Male sex and older age were associated with increased ILD risk. Importantly, nearly all patients met current guideline-based criteria supporting ILD screening. The authors' conclusions were that nearly 10% of patients developed RA-ILD within 10 years, despite treatment with modern treat-to-target strategies from disease onset. The presence of both established ILD and nonspecific interstitial abnormalities highlight the importance of ongoing pulmonary monitoring in RA patients and underscores the need for further research to determine the long-term significance of these radiographic findings. Jessica, what do you think of this?
Yeah, so a lot of this kind of fits with our understanding about RA-ILD and how prevalent it is. I think generally we say about 10% of patients with RA may develop interstitial lung disease, and so this kind of echoed that. And then we definitely think about those high risk patients being male sex and older age being associated with ILD. So we kind of have a good demographic there of people that we have to pay close attention to. I would be interested to know if there were certain specific medications that seem to do better or worse within this cohort. I also I see that they said that there was lower DLCO values and more respiratory symptom burden. I mean, I think that, those patients, if they hadn't gotten PFTs or CAT scan before this 10-year, those are, we should be, we should certainly be, if somebody's having higher respiratory symptoms, we have to keep that in mind. We should do some testing to see if they have ILD. And then it's interesting, they also mentioned these interstitial lung abnormalities. So interstitial lung abnormality basically means that there's some, abnormalities that we see on the scan. Oftentimes might be some where we call reticulations, but may not necessarily meet the definition of having interstitial lung disease. But oftentimes these do progress, and especially in somebody who's higher risk, like somebody with rheumatoid arthritis, I would say is a higher risk patient. And so we have to also keep a tighter eye on those patients that we are calling interstitial lung abnormalities, because even up to maybe 50% of those over time will develop into interstitial lung disease.
It's a really interesting thought on understanding, to your point, which therapies. And, if there was perhaps certain therapies that patients were on, did those patients have a less than 10%, risk of developing? You would assume they would,
Yeah.
but, and then if you had that data, would that change what you did in perhaps an older male patient?
Yeah.
Would that potentially make you steer against one particular class of therapy and then instead choose a different class of therapy?
Yeah. Yeah. I think one thing that we do in medicine is, we might, have a certain algorithm that we follow for drugs that we start first or second or third line. Because we don't have any like head-to-head comparisons of all of these drugs. But yeah, having some info, knowing that, maybe this one works better for interstitial lung disease or something like that might drive us to use that sooner or, first line. So yeah, that would be interesting to see as well.
I have to say it is a little bit of a bummer to know that, 10% of people, will get ILD at 10 years, whether they have been very successfully treated for their joint manifestations or
Yeah.
not.
Yeah.
That is a little, concerning to know that information. But I think also points out that we really have to continue to be astute when we're seeing our patients. Even if we say in our notes, patient's rheumatoid arthritis is in remission with no swollen or tender joints, you still have to be thinking about the lungs. And you should always, always, always be listening to your patient's lungs. Because, you can speak to this more than me, but I do think people tend to kind of get used to having shortness of breath, or they downplay it,
Yeah.
or just think, oh, I'm getting older and maybe that's why I'm having difficulty getting up the stairs. And so they're not automatically going to say to us, oh yeah, I feel really short of breath and there's crackles in my lungs, So I think, it really just points out to the fact that we need to always, even if we have patients under good control, understand that, a percentage of these people will go on to develop ILD, and we need to be listening. We need to be following the guidelines of, monitoring for these patients and doing those screenings.
Yeah. And this may change guidelines, and say, okay, well, if 10% of RA patients, even if they have, their disease is well managed, we need to be doing CTs every so often or PFTs every so often. But, Amanda, you can feel good knowing that, you've treated your patient well, and it's not, if they have ILD, there's, not too much you can do about it other than, keeping close eye on it and getting them over to interstitial lung disease group to manage their ILD, as soon as possible. So yeah, some good guidelines that could come out of that.
Yeah, absolutely.
All right. Okay. So we'll go to our second abstract. This is POS 0382, efficacy of nerandomilast in patients with autoimmune interstitial lung disease and progressive pulmonary fibrosis in the Fibroneer ILD trial. So previously we had talked about this subgroup within the Fibroneer ILD trial and the side effect profile. Now we're going to look at the efficacy. So, overview of the study, this subgroup analysis from the phase 3 FIBRONEER-ILD trial evaluated the efficacy of nerandomilast in patients with autoimmune disease-associated interstitial lung disease and progressive pulmonary fibrosis. Investigators assessed the impact of treatment on lung function decline and clinically meaningful outcomes, including hospitalization and survival. Background and purpose: progressive pulmonary fibrosis remains a major cause of morbidity and mortality in patients with autoimmune ILDs, including rheumatoid arthritis-associated ILD and systemic sclerosis-associated ILD. Previous FIBRONEER-ILD data demonstrated that nerandomilast significantly slowed decline in forced vital capacity in the broader PPF population, that's progressive pulmonary fibrosis population. This analysis aimed to determine whether similar benefits were observed specifically in patients with autoimmune-related ILD. Methods: patients with progressive pulmonary fibrosis, excluding idiopathic pulmonary fibrosis, were randomized to nerandomilast 9 milligrams twice daily, nerandomilast 18 milligrams twice daily, or placebo. Outcomes assessed included change in forced vital capacity at week 52 and time to event analyses evaluating acute ILD exacerbation, respiratory hospitalization, and death. The autoimmune ILD subgroup included patients with conditions such as rheumatoid arthritis and systemic sclerosis. Results: among the 1,176 treated patients, 325 had autoimmune-associated ILD. Nerandomilast demonstrated reduced decline in forced vital capacity compared with placebo, with effects generally consistent with the overall study population. Patients receiving nerandomilast also demonstrated reductions in clinically meaningful outcomes, including acute ILD exacerbations, respiratory hospitalizations, and death. The higher 18 milligram dose showed a statistically significant reduction in the combined risk of acute exacerbation, respiratory hospitalization, or death. Importantly, both nerandomilast doses demonstrated substantial reductions in mortality risk compared with placebo, with the higher dose associated with a 72% reduction in risk of death in the autoimmune ILD subgroup. Most deaths were respiratory related. Authors' conclusions: nerandomilast demonstrated clinically meaningful benefits in patients with autoimmune ILD and progressive pulmonary fibrosis, including slowing lung function decline and reducing important respiratory outcomes. The marked reduction in mortality risk suggests nerandomilast may provide benefits beyond preservation of forced vital capacity alone and supports its continued investigation into autoimmune ILD populations. Okay, I'll throw it over to you, Amanda. What are your thoughts?
I mean, I think it's exciting. I mean, I think, obviously this is an area and a disease that really needs more therapies. And so to have one, a newer one that is effective and better tolerated, to me is a win-win.
Yeah, absolutely. And that it's showing something that the previous antifibrotics didn't show us, which is a little bit more evidence towards some of these secondary outcomes. So mortality and hospitalizations and risk of like respiratory complications. In the FIBRONEER-ILD trial, at least within the full population, which included people with like hypersensitivity pneumonitis and included people with unclassifiable ILD. They weren't able at that time to say, okay, yes, there was an absolute statistical significance in mortality of patients on nerandomilast versus placebo. But it looks like potentially when they took out just those autoimmune-associated ILD patients, that there was a signal. And actually, in the full population, when they did the open trial, they continued patients past those 52 weeks and kept an eye on them. They did see a good splitting of patients on nerandomilast having less of these secondary outcomes, like mortality certainly seems like it's improved in those patients versus placebo. So, I mean, how exciting is that? That I can actually say to my patients, this is a medication that you're going to be able to tolerate. And not only will it slow your lung function decline, but it may actually help you to live longer or keep you out of the hospital. I mean, that's big. We haven't really had something like that for pulmonary fibrosis so far. So, yeah, I think this is a really, exciting new medication.
So I have just kind of a question that I wondered about, and you definitely are an expert, and I always learn so much from you. So why is it that if you can, obviously it's wonderful that we can reduce mortality in these patients and improve their lung function. Why don't they feel better if their lung functions are better? I don't understand
Yeah.
that.
We these medications don't stop progression, nor do they reverse the scarring in the lung. So that scar in the lung is distorting the lung tissue. It's making it so that they can't take a deep breath in, so they feel short of breath. It's also inhibiting that ability, kind of that ability of oxygen to perfuse from the alveoli to the capillaries, and so that oxygenation, is poor as well. So, these patients, it's a lot of mechanical, um, impairment on the lung. They just can't take a deep breath. And even though we can kinda slow the fibrosis from continuing on, we can't take away what's
Ah,
already there. That scar tissue that is already distorted the lung, or making it stiff and making it so the patient can't take a deep breath in. So they feel very restricted. And, so unfortunately, we don't have anything really yet that really tackles, like, getting rid of fibrosis. If we have something that can get rid of fibrosis, we can finally make patients feel better. But I will say that pulmonary rehab is the one thing that I offer patients that, even with fibrosis, that makes them feel better, because if we can support all the things surrounding the lungs, so the muscles and the cardiovascular system, and help those to perform better, they do feel improvement in their dyspnea. So, a shout out to pulmonary rehab, but yeah, we don't have anything for, really to make patients feel better yet. Lung transplant is another one. We could transplant people. They no longer have fibrosis, but now they have a new disease, which is lung transplant. It's a whole nother, we call it its own kind of disease process, because it's, requires, lifelong immunosuppression and medications and things. But, yeah, I hope that answers it. It's a tough disease. These patients, it's hard to make them feel better.
well, and I mean, to speak to that from a rheumatoid perspective, right? Like we tell people that all the time, like you want to prevent it from happening in the first place, because
Yeah,
once it happens, it's done.
yeah,
Once the joint is destroyed, yes, I can prevent further joint damage, but I can't help you make your fingers work better if there's already significant damage to them. So that does actually
yeah.
make a lot of sense
That's
to me.
exactly the same for the lung. There's
Yeah.
already damage there. I can't get rid of it. It's already causing you, just like your joints, you can't pick something up because the joint is just, destructed. Same with the lung. It's already kind of destroyed, and you've got some shortness of breath due to that restriction.
Which I think further reiterates the importance of early detection and
Yeah.
early treatment.
Yeah.
And,
That's been a theme
so
throughout all these abstracts, hasn't it?
it
Yeah.
has, and for good reason. And I think, hopefully as, we continue to see more data and have more studies, it will just help guide us more in terms of actual guidelines, early detection, early screening, before, significant fibrosis occurs.
Yeah. Yeah. Absolutely.
Well, thank you so much. That brings us to the end of our EULAR ILD wrap-up series. A huge thank you to Jessica for joining us and sharing her expertise across the series. We hope this series helped break down the most important updates on ILD from the 2026 EULAR Congress and gave you some valuable takeaways from your clinical practice. If you've enjoyed this episode, be sure to follow RhAPPcast so you never miss an update. And don't keep it to yourself. Share this podcast with your friends and colleagues. You can follow RhAPP on social media for more education, updates, and community discussions. Find us on LinkedIn under Rheumatology Advanced Practice Providers, Instagram and X under @RheumAPP, and of course on Facebook as well. Thank you for tuning in, and we will see you next time on RhAPPcast.